Hello, hello. Thank you for joining us for this GAPP MASLD MASH Community Network program. This has been sponsored by Madrigal Pharmaceuticals and, of course, by GAPP, and just really, really lucky to have this space to be able to talk about things that are really kind of important in this MASLD and MASH community. So, my name is Cheryl Walsh. I am a certified nurse practitioner, acute care nurse practitioner. I work for GI Alliance, and I've worked with them for the past 3 to 4 years, and prior to that in another GI capacity, general GI and hepatology, as well as some sprinkling of the IBS and all of that other sort of stuff in Northwest Arkansas. And our office is actually in Springdale, Arkansas. So this QRS code is a great way to register for this meeting. We'll leave it up for just a couple of seconds or a minute. Okay, so what we're going to do today is we're going to dive deeply into this MASLD pharmacotherapy, which is in these times is really shifting and changing so much for all of us. So what you're going to see here first is this current available treatments for the dysmetabolic management of MASLD and MASH. And what we're seeing is this whole sort of pie chart, or basically a peace sign if people have looked at it as well. And when we look over at that first top portion on that left side, we're seeing the systemic targets, and which is really the foundation of this treatment, these treatments. And in my practice for so long, all we ever had was this lifestyle changes when patients would come in with elevated liver enzymes suggesting MASH, or what we used to call NASH or NASLD. And really, we said, I'm sorry that you have this. You're going to have to look at weight loss. You're going to have to look at changes to your diet and becoming more active physically. And that's great. And we still know that weight loss of 7 to 10% really can have resolution of those symptoms, or those MASH and MASLD. But that's kind of hard to sustain, trying to get somebody to keep that going for quite some time. We do have some weight loss medications. We don't want to forget about bariatric surgery. BMI greater than 35 really can make a difference for some of these patients, but also, once again, noting that bariatric surgery is a big step, right? Like, there's going to be a lot of changes that are going to need to be made. And for them to lose 7 to 10% of that weight is a much bigger space than somebody who isn't necessarily with a BMI of greater than 35. And then when we look at some of these newish weight loss medications that are out there, we've got the GLP-1 receptor agonists. That's medications like Trulicity, Victoza, Ozempic. And then we have those GLP-1 GRP receptor agonists that looks like Wegovy, Mounjaro, Zepbound. And just to kind of get back to those names, because there's so many names for these GLP-1s. Tirzepatide is also known as Mounjaro or Zepbound. And then we have semaglutide, which is also known as Wegovy or Ozempic. And prior to March 2024, really all we had were those lifestyle modifications. So then when we move over to that right side, we want to look at reducing that cardiovascular disease risk. We want to look at treating that type 2 diabetes, maybe even involving the endocrinologist, and looking at that hyperglycemia, hypertension, dyslipidemia when somebody's coming into your office and they have these cardiovascular risk factors. Really saying, we probably need to take a look to see if this is suggesting that you have MASH or MASLD. And then looking at some targets for NASH, liver-directed treatments. We're going to look at these throughout the rest of this presentation. In other slides, we'll look at some vitamin E, pioglitazone, and then a resmetirom. So, GLP receptor agonists. What actually is this? Well, actually, we have our own endogenous GLP-1. We make it on our own. And GLP-1 is an endogenous hormone in our digestive system that directly acts on the hypothalamus to promote satiety or fullness and reduce energy intake. It's achieved through stimulating glucose-dependent insulin secretion, suppresses glucagon, and delays gastric emptying, which I think we really have seen a lot of with regards to semaglutide, for instance. Maybe not as much with the tirzepatide. We are finding that there are somewhat less side effect profiles with that. But what we really need to remember is that semaglutide, and we will once again talk about this in just a minute, is how that has now also been approved for MASH. So what we see here after food ingestion, we just talked about that. They're analogs of the gut-derived incretin hormone, glucagon-like peptide, and GLP-1 receptor agonists. They lower the blood glucose and they cause weight loss. So let's take a look at the semaglutide. What we've seen here is that this was approved on August 15th for the use with MASH or MASLD, 2.4 milligrams once weekly, and it successfully met both primary histologic endpoints at 72 weeks. And what it did was it showed a significant mass resolution without worsening of fibrosis, 28.9% in placebo. And then it also had a significant improvement in liver fibrosis without worsening MASH. So, really, what are we looking at? When are we going to consider something like this for our MASH MASLD patients? We're going to look at this for the overweight patients that are going to take a higher priority also with the type 2 diabetes, and given to those with MASH or fibrosis, but we want to really sort of stay away from that from our patients who have more of that lean MASH. How does this affect us in our practice? What are some things that we should consider? Well, I just talked about it. What we've seen is some of the side effects associated with semaglutide. We see that delayed gastric emptying, and it can be quite severe for some patients, especially at that high dose of 2.4 milligrams. So, something that we really need to consider. And then, even looking at that when we're looking at possibly doing upper endoscopy for a patient, this could increase the risk of aspiration if they're having severe or significant delayed gastric emptying. So what we're saying in clinic and with someone who's going to have an upper endoscopy is they need to stay off of that dose for 7 days prior to that procedure. And if, for instance, they are unable or they forget or something along those lines, which we have seen in our practice, usually it's a really good idea to consider canceling that procedure. So some of the ways that we can see how this might affect us in our practice and some of the things that we might want to look at. I feel as if we've become pretty adept in the GI space at treating some of these side effects, but as I stated previously, some of them can be really quite severe, and we might need to either pull back on treatment to a lesser dose, for instance. Really interesting today, I had one of the representatives for Novo Nordisk, which is semaglutide, and we were talking about the increasing of that dosage and how some insurance companies have said that if we don't increase at the rate that they have specified, that they may not pay for the medication, which even now, that might be difficult in some respects. Always making sure that we're coding correctly with that NASH/MASH coding. But she was saying, which I think is kind of nice to know, is that, if we want to slow down that taper when we start someone on semaglutide, most insurance companies are good with that. So maybe looking at, as opposed to increasing every month, maybe we look at increasing every 2 months, depending on what patients are experiencing, what their weight loss is looking like. So just something to kind of put into your ear, especially since in clinic today I was able to meet with one of the representatives who really gave me some great information. So now we're going to move on to vitamin E. So when I first started in practice, I remember thinking, okay, vitamin E is another thing that I can give to my patients who I've told, okay, you have to change your diet, you have to start working out more and exercising. But here, with biopsy proven steatohepatitis, we can give you 800 IUs of vitamin E every single day. Well, there's a lot about that that's changed. It's not indicated for diabetic patients, and it's also really not indicated. Well, it is indicated with patients without cirrhosis. And this came from a really great trial called the Pivens trial. And I was listening to someone else talk about the Pivens trial recently, and they were talking about how to remember it. And it's the PI is pioglitazone. Like I said, I can never say that word really well. The V is vitamin E, and then NS is for NASH studies. So, landmark study showed vitamin E improved liver histology in non-diabetic adults with NAFLD, what we now call MAFLD. About 43% of patients showed histological improvements, but there were limitations. Not all patients responded. Can't use in hypertensive or diabetic patients, which we just talked about. So there's a little bit of discordance here with regards to guidelines. Triple double A SLD guidelines from 2023 suggest vitamin E may improve NASH in non-diabetic individuals, but then when we get to the EASL, or EASO guidelines from 2024, they're actually saying we don't recommend it as a MASH therapy due to limited efficacy on fibrosis. But I think also for me, what I've seen with some of my patients is they're just looking for something to sort of grab onto to help with this diagnosis that we've given them. So it's not necessarily incorrect or wrong to use vitamin E. I've been finding more recently that I might use vitamin E 400 IUs daily. There's a lot of people who like those over-the-counter products, those supplements. But we do need to make sure that we're telling them if that's something that they are sort of really holding on to. There's bleeding, prostate cancer concerns. We need to make sure that we have a good discussion with them about the long-term dosage, the potential for any cardiac problems. So just sort of having a really robust conversation with our patients is so important when we're talking about some of these over-the-counter supplements. Um, so now we're going to move on to the pioglitazone. Oh, finally said it right. So when we look at that, it's a dosage of 30 to 45 milligrams per day. This is a medication that we actually can use with type 2 diabetes. The Pivens trials show there was no benefit of this over placebo for the primary outcome improvement in histologic. However, there's benefits were observed for some of the secondary outcomes with improvement in cardiovascular risk. So looking back at those other cardiovascular risk things that we looked at the beginning, hyperlipidemia, hypertension, diabetes. As we said, we can use this with diabetes patients, and it was actually a medication that was seen and started with diabetic medication. So potential risks. And I think maybe this is something that we don't want to necessarily see if we're trying to get our patients to lose weight, is there's a risk of weight gain, some swelling edema, and possibly some bone fractures, especially in women. And then there's a possible association with an increased risk of bladder cancer. So once again, just having these conversations, having the one-on-one with our patients, and letting them know that these are some of the advantages and possible disadvantages of some of these other medications out there for MASH or MASLD. So now we're going to move over to the new kid on the block. Really, really exciting about this drug. At least I'm very excited about this drug, in that we now have a medication that truly is liver specific targeted therapy. This was approved on March 14th, 2024. So we're almost a year and a half into this, received FDA approval in conjunction with diet and exercise. So we really love that as well, in that I think from the beginning, I used to say, I'm really looking forward to a medication to help my patients, but I don't want them to just think that they can just take the pill and they don't have to work on diet and exercise as well. So this is a treatment for adults with non-cirrhotic, non-alcoholic steatohepatitis, NASH or MASH, with moderate advanced liver fibrosis consistent with stages F2 to F3. So resmetirom is a thyroid hormone receptor beta agonist. It's a lot easier to say THR beta or THRB. And it selectively binds to and activates the THR beta receptor in the liver. Um, it is different than THR alpha, which does not have any effects on the liver and more is associated with the heart. So let's look at this next slide. We're going to look at the physiological relationship between the thyroid and the liver. So I don't know about you, but I never really thought of the thyroid and the liver having anything to do with each other, to be honest. But TSH regulates many metabolic activities in the body, including glucose and lipid metabolism in the liver. THR beta is the predominant isoform in the liver, and it's vital in maintaining normal lipid regulation and mitochondrial function in the liver. So, in patients with MASH, the THR beta is impaired, which causes this cascade of dysfunction with an inability for fat to leave the liver and creating an inflammatory response with the possibility of increasing fibrosis. What THR beta in resmetirom does is it improves mitochondrial function, and it is the only targeted liver therapy out to date. So let's also move on to how we studied this on that next slide. So the study for this was called the Maestro-NASH. It's an ongoing phase 3 randomized controlled trial of resmetirom in NASH/MASH with liver fibrosis. The trial studied adults with biopsy-confirmed NASH and a fibrosis stage of F1 all the way through to F3. So 966 patients randomly assigned 1:1:1 ratio to receive once daily resmetirom in doses of 80, 100 milligrams or placebo. And what we were looking for here were two primary endpoints that were met at week 52, almost at 32, sorry, 52. And these are actually hard targets to hit at 52 weeks if you think about it. And resmetirom achieved both primary endpoints. And when we go back to the trial, the Essence trial for semaglutide, that went out all the way to 72 weeks. So we're looking at significant improvement, NASH resolution, including a reduction in NAFLD activity score by greater than or equal to 2 points with no worsening fibrosis, and improvement and reduction in fibrosis by at least one stage with no worsening of that NAFLD activity score. And so I think that's something that's really interesting, especially if you're looking at a patient who is that F2, F3, or maybe they're that F3, and you're just wondering, like, are they kind of bridging over into? So we're seeing patients going from F3 potentially all the way down to F1, possibly and more likely to F2 in that beginning, but maybe looking in the future all the way to that F1, which is just so exciting. So let's take a look at some of the safety profile on that next slide. What we saw, we're going to go to the next one. My sweet person is helping me with advancing these slides, so occasionally we might not go back and forth. Anyway, so we looked at this Maestro-NASH phase 3 safety. Diarrhea and nausea were more frequent with resmetirom than with placebo. And what we're seeing is that that typically resolves itself within the first few weeks of the course of resmetirom. The incidence of serious adverse events was similar across trial groups. If you look at that serious adverse events and you look at that placebo on that left of 11.5, and then you see even the highest dose of resmetirom at 100 milligrams with only 12.7%. And then you do see some increase, like we said, with that increased dosage of some diarrhea and nausea. But once again, these typically are very short-lived, and I think that's something nice that you can tell your patient. You can say, you may experience some of these symptoms. We can always use some adjunct antidiarrheals or anti-nausea medications while we are getting the resmetirom into your system to help with some of those side effects. So let's once again look at those primary endpoints at this next slide. So what we saw here is resmetirom 80 milligrams and 100 milligrams were superior to placebo with respect to NASH or MASH resolution and improvement in liver fibrosis by at least one stage. So remembering and going back to those primary endpoints, NASH resolution with no worsening of fibrosis, 29.9% of patients on 100 milligrams compared to 9.7% of patients in placebo. And then fibrosis improvement by greater than one stage with no worsening of NAFLD activity score, 25.9% compared to 14.2%. And we also see very robust numbers with resmetirom at 80 milligrams. So just a really amazing drug that's really targeting liver fibrosis. And remembering that we want to jump on that fibrosis so that we are not having worsening of that, then moving into that cirrhotic stage 4. So let's take a look at that next slide. What are some of the considerations for managing MASH with resmetirom? It's ideal for patients who are non-cirrhotic with MASH. Remembering that fibrosis score that we have seen through non-invasive testing, either with maybe a FibroScan or FibroSure. For instance, in my office, we don't have a scanner yet, so we're using the FibroSure, NASH FibroSure, and we're also using the Fib4 to find out those stages for our patient. We're using ultrasound suggesting increased echogenicity, and those are enough to be able to tell us that this patient would be benefited from using resmetirom, and improved in conjunction with diet and exercise. Once again, really coming back to the foundation of treatment that we have been using for so long. So let's also take a look because there are some considerations for some drug-to-drug interactions. So what we see here, if we start over on the left, because this is a little bit of a lot, that doesn't make sense, but you get what I'm saying, hopefully. And I actually think that maybe taking a picture of this isn't a bad idea to have as a reference for yourself. So medications to avoid strong 2C8 and or OAT-P1B13 inhibitors. I, in my office, really don't see these a lot. Um, I might see some clarithromycin, but not very often. I think then when we move over to tolerated, but with resmetirom dose reductions, you want to look at clopidogrel, maybe looking at a dose reduction with regards to that. Maybe if there's someone's on 100 milligrams, you might want to look at dropping that down to 80 milligrams. The Deferoxamine is an iron chelator, not necessarily seeing any need for dose reduction unless you're seeing some worsening. And then when you have the triamcinolone, if someone's on it for short term, we don't necessarily need to dose reduce, but if they're going to be on it for a while, we may want to look at that. If they're on that Bactrim for a long period of time, we may want to look at dose reducing. And also what we want to let you know is that there is, besides that 180, there's also a 60 milligram dosage for resmetirom. So you have that ability, so say if someone's on 80 milligrams, to be able to dose reduce to 60. And then moving over to that right side, where we see medications at risk of increased exposure due to resmetirom. I think the biggest one on there is probably the Montelukast, and really there's not really necessarily a need for that dose adjust. And then moving down to our statins, and these are really something that's quite important to take a peek at and noticing what your patient, if they come into your office and they're on a statin, where do we want that maximum dose of that statin to be? And recently I was speaking with another colleague and we were saying, is this something that we reduce on our own? Do we let the primary reduce it? I think what it comes down to really is communication. If I'm going to dose reduce simvastatin from 40 down to 20, for instance, I want to let that primary care know the reason why I'm doing it so that when they go see their primary, they're not saying, well, why did they reduce your statin? What's up with that? And the patient likely will go, I don't know, they just told me to do it. So really kind of either maybe sending a little note to the primary saying, hey, I just wanted to let you know we're putting them on resmetirom, and it's suggested that the maximum dose of simvastatin be 20 milligrams. And that way they feel like they're in the know of what's going on within your clinic, right? So let's move on to that next slide. So what we see here are some practical considerations for managing MASH with resmetirom. So there's a lot of ongoing eval of this that continues. How long are we going to keep a patient on resmetirom? What are we taking a look at? What are the cutoff points? How often are we going to be doing testing? When are we going to be doing restaging with non-invasive testing? Recently, the ACD Journal article in 2024, and I apologize, I don't know the exact one, but they did come out with some preliminary guidelines that have been talking about with AASLD and the ACG. In my practice, when I put a patient on resmetirom, I typically, especially if their liver enzymes are elevated, I will typically do labs because I'm a lab person. We'll do labs at 1 month, then at 3 months, and then usually I'll branch out at 6 months after that. And then at 1 year, I'll likely look at restaging, giving the chance for the drug to really be in their systems for a year and looking at that non-invasive testing. If there's a possibility for fibroscan and you have one in your office, great. Repeating a fibroscan, repeating an ELF, maybe taking a look if that's a possibility in your office as well to do an MRE for something like that or CT. And I just learned this. I think this is really interesting and amazing, especially when we talk about the fact that Madrigal is supporting this presentation. Madrigal will actually pay for non-invasive testing $500 a year if a patient is having problems with getting some of that non-invasive testing paid for by their insurance company. So, giving us the ability to reach out to this pharmaceutical company who really wants to help and make a difference in patients' lives at decreasing fibrosis and patients hopefully stopping that journey to cirrhosis. So let's look at that last slide. It's still, once again, looking at some of those practical considerations for managing with resmetirom. Um, you know, we have been out for a year and a half now, and we also have just recently gotten approval for resmetirom in Europe, which is absolutely wonderful. So, obviously it's going to depend on a lot of insurance coverage. Making sure that we're charting and that we're coding correctly in that MASH code, that MASH/NASH, if your system hasn't translated to MASH. Doing that period of staging and lab tests for monitoring. You know, maybe you're doing a repeat of a fib 4, for instance, at month 6, or repeating that ELF or some of the fibroscan. We're going to need to look and see what duration of treatment recommendations. And I think really that is just going to be coming, it's all going to be sort of coming out more so as we keep managing and going with this medication. Multiple agents currently in clinical trials. Really exciting times. I think we're going to definitely have some more options in the future. There are several, I think actually a couple of medications that are in stage 2. So I think in the next 5 to 10 years, maybe 5 to 7, we're going to really have some other options that are really going to help our patients in this space or this landscape that for so long all we had was these foundations of you need to change your diet, you need to start working out more and losing that weight. And I do want to circle back to one thing when we're talking about those foundational qualities. Yes, resmetirom is awesome. Yes, we want to talk about diet and lifestyle changes, but I think we also have to be very cognizant of having these conversations with our patients. Some patients have significant dietary histories that may be skewing that reason for them to want to lose weight, or they've done this their whole entire lives and they don't know what else to do. Or if you look at the ethnic space, I have a lot of Hispanic patients, and when we talk about the Mediterranean diet, for instance, that doesn't necessarily speak to their culture. So being culturally sensitive with Asian the Asian population as well. Yes, we can say go Mediterranean diet, but what does that mean culturally for other people? So just being aware of those types of things. I wanted to thank you so much for listening to this presentation today. Um, this is another QR code that you can look to for additional disease state education and Resdifra webcast. And now, since there's actually people here, if you guys have any questions, please don't hesitate to ask. And then once again, we'd appreciate your feedback. You can take a short survey about your thoughts on today's presentation.